Sure, that people will still trickle in, but we'll go ahead and let you get started.
Okay. All right. This is kind of weird. I haven't done very many of these.
You're going to do great.
First of all, my name is not the first one on the title because this was originally done by Dr. Dion. In 2013, she was an attending of ours. She was over at Baptist for a while. Now she's in private practice, and this was her grand rounds. It was DSM-4. At that time, so what I've done is I just updated it in DSM-5 because it was a really good presentation. As such, it changed. So originally I was supposed to be doing eating disorder, but in the DSM-5, it's actually feeding and eating disorders now. They took over things like rumination and pica and put those in the same category. So that's how that starts. I think Dr. Dion put all the pictures in here. I haven't put any pictures in here, but I thought they were pretty good. So the first one, again, is just like it starts early. So you see a picture of a little girl weighing herself. So I think that's something that's kind of really interesting how it starts. We don't have a scale in our house, and my daughter, who's 12, has never had a fictitious body style doll or a thing like that. So no Barbies or anything like that in our house. She's always had kind of like a body neutral type thing. Like Disney had this style of like just dolls that were princesses, but they didn't look like they were Barbie. So that's what we've had in our house for this very reason. I've always enjoyed this topic because it's just really interesting how media and influences can impact people's lives, especially in this one. So again, we're going to review the DSM-5 criteria, discuss medical complications because y'all are pediatricians and that's really important. Review psychiatric treatment and just kind of examine some images and things like that you might see. I go really fast and I apologize. I'm tangential. I get bored. So I start talking about something that comes up. I apologize for that. That's why I also like to sprint feed and give you all the slides that you need. So first of all, where's this come from? 1689, Richard Morton coined the term nervous consumption. And that was supposedly one of the first anorexia type diagnoses that came about. 1874, Sir William Gull in England and Charles Lassalle of France coined the terms anorexia nervosa and anorexia hysterique, respectively, describing the symptoms of self-starvation and preoccupations with anorexia nervosa. In 1980, bulimia nervosa was recognized in the DSM-3. So it's kind of really interesting to just how, again, I like to say modern psychiatry, at least with child psychiatry, basically was born in the 80s. So feeding and eating disorders, according to NEDA, that's the National Eating Disorder Association. It's a really good resource. I would say the resources I use for the most part were the American Academy of Child and Adolescent Psychiatry Practice Parameters that was published in 2015. It is a great resource for eating disorders. It tells you exactly what you should do and gives you all the reasons why. It's like a 14-page document. Again, it's on the American Academy of Child and Adolescent Psychiatry website. NEDA has its own website, which is really good. Has basically all the information you can want about each different category of feeding and eating disorders. So most of this comes from those sources, that and obviously the DSM-5. So about 10 million women and 1 million men have an eating disorder of some kind. There's a rise in incidence of anorexia in young women every decade since the 1930s. Incidence of bulimia in 10 to 39-year-old women tripled between 88 and 93, and it keeps growing. 42% of first and third grade girls want to be thinner. Where is this coming from? That's the thing. The milestones at this age are play. 46% of 9 to 11-year-olds are sometimes or very often on diets. Again, I think a lot of this comes from like media influences and maybe what's going on in the home. 50% of girls between the ages of 11 and 13 see themselves as overweight. This is interesting. I talked to my daughter about that. My daughter's an athlete and she's very strong. So she weighs more than her friends. So we kind of de-emphasize what weight means. We're my poor children have been educated nonstop because my wife is a family practice doctor, and we've talked about how muscle weighs more than fat and things like that. 25% American men and 45% of American women are on a diet on any given day. And what I mean by that is like a weight loss diet, because obviously if you're eating food, that's your diet. Anyway, Americans spend over $40 million on dieting, diet-related products each year. There's a lot of money made on that, obviously, $40 billion. Probably more than that, but that's kind of an interesting fact. I love Disney. My kids love Disney. Are any of our Disney princesses body normal? Look at Pocahontas. And it's kind of interesting too. Crystal Bullard, who is of Indian descent, I remember one time, you know, she told me she didn't like Pocahontas because she said, it's not like my people were running around wearing these deerskin mini skirts and a bustier. It's kind of ridiculous. I don't think it's meant to be ridiculous, but that's kind of like what's going on there. Again, some other things, 47% of girls 5th through 12th grade reported wanting to lose weight because of magazine pictures. 69% reported magazine pictures influenced their idea of perfect body shape. I was at the checkout counter yesterday buying groceries, and it hasn't changed despite the internet influence. When you check out at a grocery store, you're going to see who's lost weight, who's gained weight, and things like that on magazines like People. The internet impact is really exponentially expanding. Social media, Instagram, TikTok, and that's really interesting because I know I know none of y'all, because I can't see or hear you, I know none of y'all are on TikTok right now, but I like to use what's going on and find out what's going on right now, and there is a thing called Catfish on TikTok that has 2.3 billion views. Now, some of those obviously are people noodling, but anyway, there's something called, I think, Catfish Makeup, where you can see the Catfish Challenge or something like that to see what it looks like before and after type stuff. And I've shared that with my daughter because, again, the stuff on the internet is it's almost like special effects. There was one woman who took a picture of herself, it looked great, and then she showed afterwards that one of her friends was holding her skin back and cellulite back, and they framed it a certain way where you couldn't see it. I will tell you that some good things have been happening. I get Sports Illustrated because Clemson's been in a lot lately, and I got the Sports Illustrated swimsuit issue the other day, and everybody was in it. There were plus size models, there were the traditional models, there was even a trans model in it this year. So I think some people are starting to take notice and be somewhat helpful in this category. But here's some other pictures. Again, common magazines, things that you might see, things that kids might compare themselves to. So why is it a problem? Eating disorders have the highest mortality rate of any mental illness. That's very concerning. 5 to 10% of the folks with anorexia die within 10 years after contracting the disease. 18-20% will be dead in 20 years. Only 30 to 40% ever fully recover. Mortality rate with anorexia is 10 times higher than the death rate of all causes of females for age 15 through 24 years old. This slide's really interesting because it just kind of gives you a good idea what's going on. So in 2013, when Dr. Dion originally did this lecture, the average woman was 5'4" and weighed 140 pounds. Now in 2020, the CDC says the average woman is actually 5 feet, 3.7 inches tall and weighs 170 pounds. The average American model, again, the asterisk is non-plus size, is 5'11" and weighs 117 pounds. Barbie, for instance, also is 5'9", 110 pounds, with a BMI of 16.24, a bust of 39, waist of 18, hips of 33, and a shoe of 3. And what that basically means is Barbie would have to walk on all fours if she were a real person. These are just some other examples. Most fashion models are thinner than 98% of American women. It's a combination of genetic, biological, psychological, family, environmental, and social factors, which can a lot of our mental illnesses are. Pathogenesis, just a history of dieting, childhood preoccupation with a thin body, and social pressure about weight. Sports and artistic endeavors, in which leanness is emphasized in sports, which scoring is partly subjective. You know, traditionally things like wrestling and things like that, where you have regular weigh-ins. Studies conflict with like sex abuse and things like that, and stressors. And genetics, women with first-degree relatives who have an eating disorder more 6 to 10% increased risk for developing eating disorder. Linkage studies, bulimia nervosis related to chromosome 10, anorexia, chromosome 1p. And these are the eating disorders now. It used to be something just like anorexia, bulimia, and eating disorder not otherwise specified. Now we have anorexia nervosa, which is pretty traditional, bulimia nervosa. Now we have binge eating disorder, other specified feeding and eating disorder, unspecified feeding and eating disorder, ARFID, which is avoidant restrictive, pica, and rumination got added. I don't know if you can see my mouse or not, but pica and rumination used to be in feeding disorders as opposed to eating disorders. But this was added to this category with the DSM-5. I don't know if that's what you wanted me to talk about or not, but I included it anyway. So screening, this is just for your information. These are just the different eating disorder screens. I personally like the that NIDA has an online screen. You can go and it just has like, you know, levels of how preoccupied with your weight and thinness and things like that. It's just a picture of somebody that has anorexia. A before and after, a boy who had anorexia before and then after treatment. It's more prevalent in industrialized societies. Lifetime prevalence in females, again, this is according to the NEDA. Lifetime prevalence in females is 0.9 to 2%. Lifetime prevalence among males is 0.1 to 0.3%. So what is anorexia nervosa, technically speaking? It is restriction of energy intake relative to requirements, leading to a significant low body weight in the context of age, sex, developmental trajectory, and physical health. Again, less than minimally normally expected. There's an intense fear of gaining weight or becoming fat, or persistent behavior that interferes with weight. That's really an important part compared to ARFID. In ARFID, people don't have a fear of gaining weight. Distorted perception of body weight and shape, undue influence of weight and shape on self-worth, or denial of the medical seriousness of one's low body weight. This is interesting because there usually is like, when you ask somebody with an eating disorder, how much do they want to weigh? They may weigh 89 pounds and be 5'7", but want to weigh 60, something like that. The distorted perception of body weight, almost delusional, and it's quite obsessional at times. So what happens there would be somebody who's 89 pounds, they see someone who's 120 pounds, same height as them, and they see them as actually being thinner than they are. If you have someone with anorexia draw a picture of themselves, quite often they'll draw a picture of someone who's overweight as opposed to how they may actually look, which is really kind of interesting. And just to kind of jump ahead, the obsessional quality and the almost delusional quality of their perception are reasons why medications like Prozac or something for OCD might be helpful. And for the delusional quality, that's why something like sometimes they use antipsychotics. They also use antipsychotics in severe cases of OCD as well. So we'll talk about that a little bit more, but that's why. Specifiers. So there's a restricting type. So they're not engaging in binging and purging. Binging is purging is where you overeat and then purge it afterwards. And we'll talk a little bit more about that. There's the binge eating and purging type specifier, engaging in binging and purging in the past 3 months. And then they just added a bunch of new specifiers, like it's in partial remission or in full remission. Other specifiers are mild, moderate, severe, and extreme. So mild, the BMI would be greater than or equal to 17 kilograms per meters per second square, meters, not meters per second square, meters squared. Again, the emphasis is on BMI, not actual weight. A moderate would be 16 to 16.9. Again, Barbie would be 16.24, so she would have moderate anorexia. Severe would be BMI 15 to 15.9, and extreme would be a BMI less than 15. This kind of illustrates the perception of what someone sees. I don't know if you can see it here, but again, the skinny person imagines themselves as looking overweight, and the skinny person in the mirror sees themselves as not being overweight, actually, just being normal weight in the picture. So that's kind of interesting how the perception is distorted. Comorbidities. Depression is significant, 42%. Anxiety, significant, 48%. Substance abuse, significant, 26%. And again, that might be why medications like Zoloft and Prozac may be helpful with the comorbidities. You know, one of my mottos in consults is let's address the stress and see what's left. Other things, again, suicide is very prevalent. Personality disorders as well. What did I put down here? Personality disorders that you will see are things like obsessive compulsive personality, about 15%, avoidant, 14%, dependent, 7%, narcissistic, 6%, paranoid, 4%, and borderline, 3%. I would guess that the narcissistic would be more on the boys' side, to be honest. 56% of patients with anorexia had a lifetime history of at least one comorbid excess 1 disorder, which would be traditional psychiatric disorders. 34% had 3 or more comorbid disorders. Again, in this one study, 1% committed suicide, which was 5 times the rate in general population. Again, that's why it's important. Again, kind of listed out the most common personality disorders that you see with anorexia nervosa. Behavioral traits, fear of certain foods. And that's interesting because sometimes those foods that you fear turn out to be the foods that we also binge on, and then we may purge it later, which is really interesting. Typically it's sweets and high calorie foods. Restricted repertoire of foods, they only eat certain things. And as such, pretty much everybody I've seen with a significant eating disorder knew the calories and everything that they ate as well. Overestimating the number of calories consumed. Overusing condiments and or artificially sweetened products. Food-related rituals. People with eating disorders often like to cook food but not eat it. Concerns about eating in public. Exercise-related rituals. Last patient we had in the hospital that had an eating disorder was exercising over 4 hours a day. That manifested because that was her compensatory behavior when she was stressed out. She was on the track team and she would just run for like an hour. When COVID hit, she was stressed out because of COVID, didn't have anything else to do but exercise, and evolved into significant compensatory responses. Restlessness or hyperactivity. Inflexible thinking. Insight is not there. Insight into the illness often is not there. Perfectionism, need to control one's environment. When somebody feels that their environment is out of control, they tend to try to control what they can. The few things that we can control as kids are what we eat and what we excrete. So that's how that can kind of come into play there. Behavioral rigidity, purchasing food only in certain stores or from certain salespeople, inability to accommodate changes in schedule environment. Typical symptoms, amenorrhea. Amenorrhea is interesting because this used to be part of the criteria for old anorexia nervosa. I don't know if you noticed or not, but that was no longer part of the criteria. But it's still a common symptom. Infertility, exertional fatigue, weakness, cold intolerance. palpitations, dizziness, abdominal pain, and bloating, typically after eating. The perception of food after eating when you've not been eating can be overwhelming to some folks. Constipation, swelling of the feet, and irritability. Here's just some more pictures of somebody with anorexia. As you can see, the medical complications are profound. I'm not going to read all this out to you because that's a lot. As you see, this is maybe where you see a lot of these folks come in. Here is a patient with a BMI of 19 versus somebody with a BMI of 12. You can kind of see the difference there. Special considerations: osteopenia, osteoporosis. 30% of women with anorexia develop osteoporosis. Correlates with weight loss and amenorrhea. Free feeding syndrome, result of fluid and electrolyte shifts during nutritional rehabilitation. You get things like hypophosphatemia, hypokalemia, hypomagnesemia, and volume overload. Labs: leukopenia, mild anemia. Chemistry, you might see elevated BUNs, elevated LFTs. You might see metabolic alkalosis from induced vomiting. That tends to be on the board sometimes. Metabolic acidosis from laxative abuse, and this tends to be on the boards too. I like to think of metabolic alkalosis. You become more alkaline because you got rid of all your acid from throwing up. That's the way I like to think about it. Thyroid function, T4 in normal low range, T3 tends to be decreased. There's Keira Knightley back in the day. Typically, you'll also have low hormones, low estrogen, low testosterone, EKG, sinus bradycardia. Boy, we had the kid the other day that had bradycardia, it's like in the 30s. And we couldn't even get her to the eating disorder clinic until heart rate was out of the 30s. Higher is really kind of interesting. EEG, just have diffuse abnormalities. Brain imaging, you have increase in ventricular brain ratio. So you actually get a little bit skinnier there too, which is really interesting. Treatment, nutritional rehabilitation, medical monitoring, psychological treatment, things like cognitive behavioral therapy, dynamic therapy, family therapy. I'll go a little bit more in detail with that too. Pharmacotherapy, if you read the ACAP practice parameters, it talks about the use of fluoxetine, olanzapine. Mosley family therapy, family-based treatment, the Mosley approach. This is just going to explain what it is. This is who came up with it. Mosley is a hospital in London. It was a treatment for anorexia nervosa in adolescents under 18 in the home environment by a trained professional. Again, parental oversight of the child's diet, eating behavior in the early phase of treatment. So phase 1 is weight restoration. Phase 2, returning control over eating to the adolescent. This is a big issue, is just control. And then phase 3, establishing healthy adolescent identity. And that leads to, again, the partial remission and then the remission. So a lot of times you have family supports for the parent management of eating and related behavior until the adolescent demonstrates improvement. Improvement is, again, improved insight and willingness to participate in the treatment. Usual for most cases of like short duration anorexia nervosa and bulimia nervosa in young patients. There's adolescent-focused therapy. It targets the autonomy. The autonomy is your control of your life. And self-efficacy in terms of adolescent development. It's been subject of 2 randomized controlled trials. It was helpful and useful for adolescents with anorexia nervosa when family-based therapy was not helpful. Cognitive behavioral therapy, we talk about this all the time. Cognitive is basically individually focused therapy, targets adolescent management behaviors and distorted cognitions associated with anorexia nervosa and bulimia nervosa. Again, this tends to be the things that we catastrophize. We catastrophize about being fat. We catastrophize about gaining weight. things like that. Helps with this cognitive distortions of body image and how they perceive themselves as well. Adolescent version of CBT can be appropriate also with bulimia nervosa. Interpersonal therapy basically focuses on changing the problematic interpersonal relationships that trigger or maintain eating disorder symptoms. Basically, it works on maintaining the peace in the house, which is a very loose way of putting it. But basically, it can be helpful in bulimia nervosa and binge eating disorder as an alternative to CBT. Other things, antidepressants. So symptoms of obsessionality, anxiety and depression in anorexia nervosa and binge bulimia nervosa. And what it does, it targets the binge and eating and purging in bulimia nervosa. Prozac is indicated for bulimia nervosa in adults, and it's the cytochrome, is the 2D6, 5-HT2D6 that 5-HT2C, I'm sorry, 5-HT2C is what it helps with. That's the part of the Prozac that helps with enjoyment, energy, and it's also the part that helps with bulimia, is what they've talked about. The reason it doesn't work so well with anorexia nervosa is you don't have the building blocks of neurotransmitters due to malnutrition. And also the studies were kind of iffy. And the reason the studies are kind of iffy is motivation, the want to. The want to in psychiatry is really hard. Somebody who wants to get better from the depression is going to respond much better to antidepressants than someone who doesn't want to get better from their depression. Same thing goes with eating disorders. The want to is one of the hardest things. The want to improve your weight is very challenging in eating disorders. There's an uncontrolled trial suggesting that antidepressants are tolerated and may be helpful in adolescent bulimia nervosa. It's very useful though, however, for the comorbid disorders, which we talked about, OCD, anxiety, depression, maybe a second line indication for that. Primarily it's this therapy. Fluoxetine, which is Prozac, is also the most widely studied and has been found to decrease urges in binging and purging. It's indicated by the FDA for the treatment of bulimia nervosa, but the dosing fluoxetine in the studies was much higher than typically needed for depression. Why is that? That's because typically for anxiety and OCD, we need to use higher doses of serotonergic medications to achieve efficacy. For instance, like Zoloft is pretty helpful for depression, like 20 to 40 milligram range. Whereas in OCD and anxiety, the dose would be closer to like 60 to 80. Zoloft or sertraline, for instance, for depression, the range would be like in the 50s maybe. Whereas in the CAMS trial, the childhood anxiety multimodal study, the average dose was about 140 milligrams in that clinical trial, or that major study. Fluoxetine is indicated age 10 and up also for depression. So it's been tested safe and efficacious down to this age group for depression. Atypical antipsychotics help things with body image distortion. Again, like we saw the person who was severely underweight and saw themselves as being overweight or perceived as overweight. They also help you gain weight. But unfortunately, due to fears of weight gain, it's kind of hard to get people to be compliant too, because nowadays you don't prescribe a medicine and people are like, okay, you know, you prescribe a medication and somebody's gonna look it up on the internet. And unfortunately, there are a lot of, I don't know if there's a lot of, but there's certainly several websites out there, like pro-ana websites or pro-anorexia websites that teach kids how to catastrophize their treatment or teach them what medicines will do what. So once someone with anorexia hears that this medication may cause weight gain, they may refuse to take it. That said, I've seen it become very helpful for a lot of folks, especially if they had image distortion and severe obsessionality related to it. Olanzapine has been pretty helpful. Risperdal has been noted as so is Seroquel. So there have been some randomized control trials. There was insufficient evidence. Again, part of that's just the want to. Compliance is really difficult with antipsychotics in this population. It's really hard with the efficacy and the core symptoms of anorexia nervosa. Again, that's a lot of a want to problem. They use the atypical antipsychotics though because the potential effects on weight, anxiety, and obsessive thinking. A lot of times we will use atypical antipsychotics as an adjunct for OCD. For this reason, again, just imagine germophobia. A lot of times germophobia can almost have a delusional feel to it. Again, the acceptability of the medication is a significant problem due to fear of weight gain early on. Risperdal, olanzapine, quetiapine, they were all well tolerated, and quetiapine was found did have some evidence of greater improvement in weight and eating-related thinking in the group randomized to quetiapine, but it didn't separate from, there was not statistically significant differences between groups. It's really hard to do studies with kids. And the reason I say that is, for instance, Zoloft in the clinical trials to get it indicated for depression was 69% efficacious, but placebo is 59% efficacious. So it didn't separate from placebo. So it doesn't mean that Zoloft isn't helpful for depression in this age group. It just didn't separate from placebo. Clinical trials are much harder with kids. Bulimia nervosa. First distinguished from anorexia in 1979. Prevalence is about 1.5% and 0.5% for men. Males with bulimia nervosa have a higher prevalence of premorbid obesity. Average onset is about 20 years old. DSM-5 criteria, recurrent episodes of binge eating characterized by both eating in a discrete period of time, about 2 hours, an amount of food that is definitely larger than most people would eat during a similar period of time and under similar circumstances. And with that larger amount typically is about 2,000 kilocalories. So a friend of mine was in a sorority. She made a cake for her sorority sister for the next day. And when she went to go get it out of the refrigerator the next day, it was gone. One of her sorority sisters had eaten the whole thing. A lot of times people eat so much, it will be painful. I had a patient in residency, and she would go to Krispy Kreme and eat a dozen donuts on the way home before she ate, before had dinner. So the family thought she wasn't really eating very much food. They're like, well, I don't understand how she's maintaining her weight. But yeah, she would either like eat a whole box of Krispy Kreme donuts or a whole dozen fried chicken bucket on the way home and hide it. Typically, there's some hiding, and actually all these, it's very common for folks with anorexia to try to hide it. So they will go, one of the common treatments of anorexia is they can't go to the bathroom 2 hours after they eat. A lot of times folks will want to take a shower and purge in the shower or something like that, which is just a good sign that there's a problem and they have some insight into they're doing something that they probably should be doing. Another thing is just the sense of lack of control over eating during the episode. And that's according to DSM-5. Other things in the DSM-5, recurrent inappropriate compensatory behavior in order to prevent weight gain. So again, there can be self-induced vomiting, misuse of laxatives, diuretics, enemas or other medications, fasting, excessive exercise with bulimia. Binge eating and inappropriate compensatory behaviors both occur on average at least once a week for 3 months. Self-evaluation is unduly influenced by body shape and weight. Again, kind of a harsh self-evaluation. The disturbance does not occur exclusively during episodes of anorexia, so that's the separate. Anorexia trumps it. Specifiers in partial or full remission. Mild is 1 to 3 episodes. Moderate 4 to 7 episodes. Severe is 8 to 13 episodes, and extreme is 14 or more episodes of compensatory behaviors per week. Comorbidities: suicide, anxiety about 81%. The suicide rate is about 25 to 40% of patients with bulimia attempt suicide. Anxiety disorders, mood disorders, substance abuse disorders, personality disorders. I'm not sure why John Lennon's on that. Other things that are interesting, 95% of patients with bulimia nervosa have at least one DSM diagnosis, and 64% had 3 or more. Bulimia had a much higher rate of personality disorders. Like 21% of patients with bulimia had borderline personality disorder. Other things are avoidant and dependent. Medical history, you'll see lethargy, irregular menses, abdominal pain, bloating, constipation. You'll see the loss of dental enamel. That's pretty common sign. Again, that's from the excessive acid from purging. Dental cavities, again, the enamel's gone, so more likely to have cavities. Enlarged parotid glands, again, related to the purging. Scars on the dorsal surface of the hand, and that's usually from putting your fingers in your mouth. Sometimes people use toothbrush handles, and some people have learned that they can vomit just by thinking about it. A lot of times you'll see tachycardia and hypotension, dry skin, hair loss. This is what we're talking about, the scars. It's called Russell's sign, and that is from the purging and sticking your hand in your mouth to fill up. Associated lab findings, hypokalemia, hyponatremia, hypochloremia, metabolic alkalosis from vomiting. Again, it's because you're getting rid of your acids, so you become more basic. Metabolic acidosis, again, from laxative use. Amylase, sometimes we check the serum amylase. Other things, you see your protein-losing gastroenteropathy, hypokalemic ileus, colonic dysmotility, constipation, melanosis, cathartic colon, pancreatitis, dehydration, hypomagnesemia, hypophosphatemia, hyponatremia, hypokalemia. Metabolic, again, parotid and salivary gland hypertrophy, loss in gag reflex from repeated gagging, esophageal dysmotility. And I think a lot of that just has to do with just sometimes our pipes get confused which way the stuff's supposed to go. Abdominal pain and bloating. Heme-stained emesis from excessive emesis. Mallory-Weiss syndrome, again from retching. Esophageal rupture, again from retching. GERD, gastric dilation, diarrhea and malabsorption, steatorrhea. Treatment, again, cognitive behavioral therapy is the treatment of choice, like we talked about before. The other psychotherapies, very similar to what we talked about actually with anorexia nervosa. Pharmacotherapy with antidepressants, again, fluoxetine is FDA approved. Bupropion is contraindicated, and again, this is Wellbutrin. That is why you're more likely to have seizures, essentially, due to electrolyte instability. So bupropion is contraindicated. Combined treatments, medication and therapy is the most beneficial. And pretty much everything in psychiatry except for ADHD. There's no therapy for ADHD per se. Just stimulants are the best, and alpha-2 meds like Intunib and Cafe are pretty helpful too. ARFID's a brand new one. Avoidant restrictive food intake disorder. I've seen a couple of these actually on consults. What it is, it's an eating or feeding disturbance with apparent lack of interest in eating food. Avoidance based on the sensory characteristics of food, concern about adverse consequences of eating. So there's persistent failure to meet appropriate nutritional and energy needs associated with one or more of the following. So typically there's a significant weight loss or failure to achieve expected weight gain, significant nutritional deficiency, dependence on enteral feeding or oral nutritional supplements, marked interference with psychosocial functioning. It's not better explained by lack of available food or by associated cultural sanctioned practice, like Ramadan or something like that, I'd imagine. Eating disturbance does not occur exclusively during the course of anorexia nervosa or bulimia nervosa. There's no evidence of disturbance in the way of one, which and the way in which one body's weight or shape is experienced. So again, you don't have the distortion that is common in anorexia. It is not attributable to a concurrent medical condition, not better explained by another mental disorder. And the eating disturbance occurs in the context of another condition. The severity of the eating disturbance exceeds that routinely associated with a condition or disorder and warrants additional clinical attention. Essentially, the eating disturbance is bad enough where it needs to be treated separately. Usually folks with autism spectrum conditions are more likely to develop ARFID. Again, you saw sensory issues can be a problem with it. So if a kid has a very narrow diet, again, related to sensory issues, that can be an issue. A lot of these kids have had some kind of like vomiting issue or something like that before they got a virus and were throwing up, and then developed ARFID later on. Intellectual disabilities, ADHD, are more common. Children who don't outgrow normal picky eating or in whom picky eating is severe appear more likely to develop ARFID. So there's a pattern of behavior established early on. That's why it's important to encourage a diverse diet. Many children with ARFID also have co-occurring anxiety disorder, and they're also at high risk for other psychiatric diagnoses, according to the National Institute of National Eating Disorder Association. Typically, they have dramatic weight loss. Sometimes they will dress in layers to hide weight loss or just to stay warm. A lot of times there's constipation, abdominal pain, cold intolerance, lethargy, consistent vague gastrointestinal issues like upset stomach around mealtime. They have no cause, dramatic restriction in types and amount of food eaten. A lot of times I'll see this like when the kid developed like the viral illness or something like that, and they have a change of behavior afterwards. We only eat certain textures of food. We've had kids that had ARFID because they choked on a tortilla chip before too, and that was anxiety related. So that kid only ate soft food. Fears of choking and vomiting. Again, this can be related to, again, something that happened before, a choking incident or vomiting incident. One kid got so upset they threw up in a restaurant, were terribly embarrassed, so they didn't want to be around people anymore. And they apparent lack of appetite or interest in food. This is different from anorexia in ways, because people with anorexia obsess over food, they just don't necessarily eat it. Limited range of preferred foods that becomes narrower over time. So again, picky eating progressively worsens. And really key point there is no body image disturbance or fear of weight gain. And that's really why they added it to the DSM. Physical consequences of ARFID, similar to the other eating disorders that we mentioned: stomach cramps, menstrual irregularities, trouble concentrating from the lack of neurotransmitters essentially, and nutrition, abnormal lab findings fairly similar to anorexia, like low thyroid hormone levels, low potassium, low blood cells, low heart rate. Post-pubertal female can lose their menstrual period, dizziness, fainting, syncope, feeling cold all the time, sleep problems, dry skin, dry and brittle nails, fine hair on the body, lanugo. Usually people usually look at the back. That's the baby hair that little babies have on their backs when they're born. Again, that's usually, I think, related to cold intolerance. Thinning of hair in the head, dry and brittle hair, muscle weakness, cold and mottled hands, swelling feet, poor wound healing, impaired immune functioning, electrolyte imbalances, can kill without warning, which is important for nutrition, certain cardiac arrests. That's why it's significant. And again, a lot of the treatments are fairly similar to what we use, again, with anorexia and bulimia. The therapy, again, gives this first line. OSFED. OSFED person must present with feeding or eating behaviors that cause clinically significant distress and impairment, but do not meet the full criteria for any other eating disorders. There's some other ones that are other specified out there, and we'll talk about it, that they talked about putting in the DSM-5 and they didn't, so I'll mention some of those later, but they may fall in this category. Diagnosis then might be assigned to address the specific reason why the presentation does not meet the specifics. So another one, so like bulimia may not meet the frequency, maybe like once a month or something like that. So other examples of OSPED might be, oops. Uh-oh. Uh-oh. My little arrow's not working. Okay, it's working. Atypical anorexia nervosa. All criteria met, except despite significant weight loss, the individual's weight is within and above the normal range. Binge eating disorder of low frequency or limited duration. The criteria for binge eating disorder met, except at lower frequency and for less than 3 months. Bulimia nervosa of low frequency and limited duration. All the criteria for bulimia nervosa are met, except that the binge eating and appropriate compensatory behaviors occur at lower frequency. Purging disorder, recurrent purging behaviors to influence weight or shape in the absence of binge eating. Night eating syndrome. This was new to me. I hadn't seen this one before. Recurrent episodes of night eating, eating after awakening from sleep or by excessive food consumption after the evening meal. It's not better explained by environmental influences or social norms. Behavior causes significant distress and impairment, and it's not better explained by another health disorder like OSPED. It's just unspecified eating disorder. Any unspecified in the DSM basically means I don't have time to come up with a more specific diagnosis at this time, or I don't have enough information. Basically is what unspecified means in the DSM. So again, does not meet full criteria, and the clinician chooses not to specify, or there's insufficient information. So that might happen somewhere like in the ER. Pica. This is a feeding disorder, not an eating disorder. But they've included, again, the DSM criteria as feeding and eating disorders. Persistent eating of non-nutritive, non-food substances over a period of a month. So again, and we had the kid that swallowed the tweezers last I don't know, I guess last month. So did he get pica? Well, no, because he only did it once. But did he eat something he wasn't supposed to eat? Yes, he did. So persistent eating of non-nutritive, non-food substances over the period of 1 month. I used to work in dialysis. I used to see this all the time. People in dialysis typically would eat clay. Eating of non-nutritive, non-food substances and inappropriate to the developmental level of the individual. What that means is, say I've got a kid with autism and developmentally is about a year old. 1-year-olds tend to put stuff in their mouth that they're not supposed to. Now, a neurotypic 16-year-old eating things they aren't supposed to. I see this sometimes with eating disorders. And there's an overlap there. So folks with anorexia will want to feel full. So sometimes they will eat non-nutritive items. They used to eat tissue or something like that to fill them up. So they would eat like Kleenex or something like that. If the eating disorder behavior occurs in the context of another mental disorder or medical condition, it is severe enough to warrant clinical attention. So again, this would probably fit with like autism, where the kid keeps getting hospitalized because he's eating stuff he's not supposed to. There used to be a big deal about pica and lead. Lead's been banned from paint for a long time, but I feel like the PEDS folks, y'all tend to still get questions about lead. First-line treatment for pica involves testing for mineral and nutritional deficiencies, correcting those. Often concerning eating behaviors disappears, the deficiencies are corrected. But if they're not, there are behavioral interventions. Basically what this is, redirect a person's attention away from the desired object, rewarding them for discarding or setting down the non-food item, which is just essentially behavioral training. Again, all these therapies are typically outpatient. Rumination, repeated regurgitation of food for a period of at least 1 month. Regurgitated food may be rechewed, reswallowed, or spit out. I've seen this a couple of times too. A lot of times these are related to episodes of stomach bug and then learned behavior from the stomach bug or worsened behavior from the stomach bug in teenagers, or it's something that you can see more commonly with little kids. Repeated regurgitation is not due to a medical condition, so gastrointestinal condition. Behavior does not occur exclusively in the course of anorexia, bulimia, binge eating disorder, volume restrictive, food intake disorder. If occurring in the presence of another mental disorder, intellectual developmental disorder, it is severe enough, again, to get a clinical, its own clinical attention. This is how you treat rumination. And this is just actually like a straight up quote from Nita, because I could not come up with a better way of saying it. Basically, once the physical cause for rumination disorder has been ruled out, the most common way it's treated involves a combination of breathing exercises, so deep breathing techniques, and habit reversal. Habit reversal is something now it's called CBIT. CBIT is basically where you have a compensatory response. So when you feel like you're going to ruminate, you have to figure out something else you're going to do. Typical example is like if someone pulls their hair out, the competing response would be to put your hands in your lap or sit on your hands, something like that. A child with rumination disorder is taught to recognize the signs and situations when rumination is likely, so that urge to purge or ruminate. And then they learn the diaphragmatic breathing techniques to use after eating that prevent them from regurgitating their food. And they eventually learn to prevent the rumination habit by replacing it with deep breathing techniques. Sounds a lot easier than it is. And again, there's a want to issue that I have a lot of folks will go over the deep breathing exercises and they just won't do it. So again, a lot of this becomes an outpatient therapeutic concern. Orthorexia. Any of y'all heard of orthorexia? Raise your hand if you've heard of orthorexia. Dr. Lappick, I don't know if any of y'all met Dr. Lappick, but he did his grand rounds on orthorexia. Basically what it is compulsive checking of ingredient lists and nutritional labels, and increased concern about the health of ingredients. And again, this is non-DSM. Cutting out an increasing number of food groups like sugar, carbs, dairy, all meat, or animal products. Inability to eat anything but a narrow group of foods that are deemed healthy or pure. Unusual interest in the health of what others are eating. Spending hours per day thinking about what food might be served at upcoming events. Showing high levels of distress when safe or healthy foods are not available. Obsessive following of food and healthy lifestyle blogs. Body image concerns may or may not be present. This was kind of interesting because basically he showed me someone who'll spend 3 hours preparing these I guess like bento boxes or something like that of food, and every food was like weighed with a scale and put in its individual compartment. Everything was like planned out to a T. It would take hours and hours and hours to do this. And that's the thing about psychiatry. If it is impairing in any way, typically that warrants a treatment or a diagnosis. So the ACAT practice parameter. What do we do about feeding and eating disorders? Again, all mental health clinicians should screen all child and adolescent patients for eating disorders. Don't just screen the females either. You gotta screen everybody. Simple questions like my screening question is, do you ever do things that are unhealthy to lose weight? Or do things that are unhealthy to, essentially do you do things that are unhealthy to lose weight? Is one of the first screening questions that I use. Self-esteem is part of the criteria for depression. So usually that'll trigger something when you're asking someone about their self-esteem. If they have mid to low self-esteem, that might be a trigger to go in a little bit more depth about eating disorder questions. Positive screening should be followed by a comprehensive diagnostic evaluation, including laboratory tests, imaging studies as indicated. Severe acute physical signs and medical complications need to be treated. Psychiatric hospitalizations, day programs, partial hospitalizations, and residential programs for eating disorders in children and adolescents should be considered only when outpatient interventions have been unsuccessful or are unavailable. For instance, we do not have an eating disorder hospital here. Usually our folks go to Veritas, North Carolina, but we do have some eating disorder specialists in town that do the therapy. And as we talked about before, the therapy is the most important part of this treatment. Again, partially because they want to get better. Treatment of eating disorders in youth usually involves a multidisciplinary team. That means that a lot of times we have diet, nutrition, primary care providers, psychologists, and occasionally psychiatrists to prescribe medications. and they have to be developmentally aware, sensitive, and skilled in the care of children and adolescents with eating disorders. Outpatient psychosocial interventions are the initial treatment of choice for eating children and adolescents with eating disorders. For instance, like Sue Nelson is our go-to person for eating disorders in town. She's an eating disorder therapist. That's really good. The use of medications, including complementary and alternative medications such as yoga, should be reserved for comorbid conditions and refractory cases, but yoga has shown some benefit in treating bulimia. And then this is just bonus stuff here. I'll just kind of go through this really quickly because I just want to go back to the resources for y'all. Y'all can do these for fun afterwards if you want to. One thing I did not mention is sometimes that we do this, if any of y'all are involved with our kid that had an eating disorder, there's a great fear with folks with anorexia about eating. And there's a lot of catastrophization before eating. So an acute treatment to get people kind of heading in the right direction, occasionally we will give a low dose of a benzodiazepine about 30 minutes before meals to ease that catastrophization and that stress. The stress will also impact their perception of the food once they eat. They will just over-somatize about the food, which makes it harder for them to head in the right direction. So occasionally we will offer like a low dose Ativan or something like that pre-meal. Not saying you have to do that, but it's something that we have done before in the past. There's not much data on that, but again, it kind of makes sense if you think about it. These are just Dr. Dion's questions, if you want to look at them. I'm trying to get to slide 93. I guess, is there a way, I mean, I guess y'all could chime in if y'all have any questions. Anybody remember anything I said after TikTok? And I made sure to include just like the best resources that I could find. It's fairly straightforward. These cases are much easier to remember and easier to understand if you have some association with it. If you had a patient or something like that. But basically, ACAP has a nice eating disorders practice parameters. You go to the AACAP website, go to practice parameters. They also have facts for families, and there's a facts for family, which is a handout for parents about weight. The DSM-5 is obviously something I use. This is what we use for diagnostic purposes. The National Eating Disorders Association has information. It has screening tools, a helpline, and resources. And what I didn't mention, but prevention is really important. I think we kind of talked about that media, social media impact on it, but prevention is obviously first line, what we want to do with mental health and in primary care. So there's a lot of prevention measures and things like that on this website. So I would definitely recommend checking out the National Eating Disorders Association website. And again, they have the screening tool is pretty helpful, a helpline and what you should do. I don't know if y'all are Gamecock fans, but you know, the Gamecock quarterback's brother committed suicide, and it talks about that all the time whenever the Gamecocks play anyone, which is nice to bring about awareness, but I never mentioned any suicide hotlines or something like that about what to do. So again, the what to do is an important piece of this. Okay. Y'all have any questions? Sorry, I went through it kind of fast, but got like 90 something slides. Anybody have any questions?
I believe there's a question in the chat room.
Ooh, where do I go to that?
Go down at the bottom where it says chat. Dr. Getz, I've heard some controversy that talking about weight with patients promotes eating disorders. Are there recommendations on how to talk about weight with teens who are at risk one way or the other?
It's, you know, a lot of times it's just the way you present things. I ask tough questions all the time, and it's, you have to be in a non-judgmental manner. You know, they have to know that you're there to care about them and help them out. So it's really how you ask the question as opposed to what you're asking. If they know where you're coming from as a part of just like your health and wellness, typically that goes pretty well. I remember I used to be hesitant about asking tough questions, and now I don't particularly have too much trouble with that. So again, it's just the way you ask things. If you ask nervous about a question, they'll be like, why are you nervous about this question? And you know, it's kind of like suicide. People think that asking about suicide makes things worse, but actually it doesn't. You're more likely to help people out by asking those questions in the long run. And if it does make it worse by asking, then they're probably really close to needing help anyway. Where do I go? Oh, okay, I see it now. Any other questions, or is that helpful? Oh, okay, thank you. And I think I sent this to Scott, so I don't know how this works, but Scott may just forward this to y'all. Does that sound about right?
Certainly, we have also recorded this, and so they can go back and view it again.
You recorded this and didn't tell me?
Oh,
Oh my goodness.
don't sue me.
All right, just don't show it to my boss.
Our secret.
Okay. Anything else I can do for y'all? If y'all have any questions later on, I think most of y'all have my cell number, or y'all are really good about touching base with me. So I hope this was helpful for y'all. Thank you. I learned a lot in doing this, and hopefully that'll be helpful for y'all.
Thank you so much.
Yeah, thank y'all. Y'all take care.
You too.